Hello, this is Scott Bragg presenting on making renal dose adjustments. Guidance on which tool to prefer for measuring renal function is changing. Historically, drug dosing was determined by creatinine clearance, but more recently, eGFR is being recommended. Please follow the QR code for a short quiz on this topic before diving into nuances in this video. I hope by the end of this video and case-based facilitation, you can identify evolving guidance on making renal dose adjustments via creatinine clearance or eGFR. Recall the difference between indexed and non-indexed eGFR, and adjust drug dosing in simulated patient cases. Many medications require renal dose adjustment as renal function declines to reduce the chances of drug accumulation. Unfortunately, many medications are not adjusted in patients with CKD, and this leads to more side effects, higher costs, and longer hospital stays. Measuring inulin clearance is the best way to determine GFR because it's only filtered in the glomerulus without renal secretion or reabsorption. It's rarely used in practice, though, secondary to costs and complexity issues. Cheap and readily available markers like creatinine or cystatin C are used alternatively. Most renal function formulas use serum creatinine to estimate renal function, but many issues exist. Factors impact creatinine formation and clearance. Sarcopenia in older adults make these assessments difficult. Using serum creatinine to estimate accurate renal function is not possible in an AKI considering its short half-life. The CrCl formula was developed in the 1970s to estimate renal function and dose adjust renally eliminated meds. It uses age, weight, sex, and creatinine to estimate creatinine clearance. Problems can arise, though, as creatinine concentrations may fluctuate and it undergoes slight proximal tubule secretion. Making dose adjustments in patients with higher weights remains difficult. Creatinine clearance based on actual weight may overestimate renal function. Consider using an adjusted body weight for calculations if patients are more than 130% their ideal body weight. Here's an example protocol with different thresholds for making renal dose adjustments on various meds. Dose adjustments often occur when clearance falls less than 60, 30, and 15, but this varies based on the drug. Following your institution's dosing guide is important, but refer to the package insert if no protocol exists. The CKD EPI equation is a new formula released in 2009 and updated in 2021. It improves accuracy over CrCl for estimating renal function, so it's recommended in guidelines for staging CKD and more recently drug dosing. It has the option to add cystatin C if known to improve calculations. eGFR equations do not use a patient's weight when calculating clearance, assuming it's an adult patient of average weight and height. This indexed or standardized body surface area may be less appropriate in patients with weight extremes. A non-indexed eGFR can be calculated if knowing a patient's body surface area to improve clearance estimates. When calculating eGFR, units are reported in milliliters per minute per 1.73 meters squared. This was the average body surface area almost 100 years ago, and this has changed with time. Take note of this image on the right to highlight when eGFR estimates are over and underestimated. Historically, creatinine clearance has been determined to help renally dose adjust drugs. The 2021 CKD EPI equation is the preferred equation to determine eGFR, which is used for CKD staging. Recently, guideline groups have even started to prefer eGFR for drug dosing adjustments. The 2024 KDIGO guidelines recommended using eGFR for drug dosing because it's a more accurate estimate of renal function. Package inserts may say dose based on creatinine clearance, particularly if drugs were approved before 2005. This changing guidance to prefer eGFR for drug dosing started around 2010, but may apply to all drugs soon. These are a few meds who have historically been dosed using the CrCl formula. Note that the preferred weight for these calculations may vary depending on the drug. Many meds approved after 2010 started using eGFR calculations for drug dosing as seen in their package inserts. Looking at the package insert for meds may provide context clues on which renal dose adjustment formula to prefer. Some labels may state units or even use terminology like eGFR from outcome studies like this Jardian's package insert. When in doubt, ask for help and consider patient response to a med. Automatic calculations are made in many EHRs for both creatinine clearance and eGFR. An updated CKD EPI equation was implemented in 2021 to improve health equity for Black patients, but this change may not be reflected in results prior to this date. Consider nuances of patient when calculating clearance and making dose adjustments. Don't think of these tables outlining the recommended dose with different clearance numbers as a hard and fast rule. Consider the indication for a drug, its side effects, and precautions if making the clinical decision to dose adjust or not. Work with other members of the care team to make these decisions. There may be mixed recommendations on how to dose adjust meds if comparing creatinine clearance and eGFR. Using clinical judgment is key depending on the drug and patient factors. Monitoring drug levels may help with certain meds, but observing patients closely is important if dose adjustments are made or not. Be careful with medication adjustment in older patients, those with sarcopenia, and patients with weight extremes. Using standardized protocols on when various meds should be dose adjusted may help to minimize errors, but don't forget about what the drug is being used for, side effects, and effectiveness. Here's an outline for a seminar we've planned practicing making renal dose adjustments. We'll compare and contrast formulas, renal dose thresholds, and other nuances with 3 cases. Please complete our post-session quiz following this QR code after the seminar to refine this teaching module.